Hello, it's Bruce Williams again. Today I would like to give the 5th lecture in a series on the gross pathology of the eye. As I do at the beginning of all of my lectures, I want to thank those individuals, colleagues, and friends who have provided me with these images either directly or through online collections, which allow me to put these lectures together. In the last 3 series of lectures, we are going to talk about the miscellaneous diseases of the eye. We've already covered the bacterial and fungal and viral diseases. Now we're going to cover those diseases which pop up for a variety of other reasons. Well, we're going to start in the front of the eye today, and the anterior chamber is a pretty good place to start. The presence of hemorrhage in the anterior chamber is called hyphema, and it has a number of clinical appearances, including a diffuse filling of the anterior segment with hemorrhage, a layered filling of the anterior chamber or the anterior segment with hemorrhage, in which you can see that the blood has come to the bottom of the eye, and it may actually be stratified, with the bottom layer actually turning reddish black as it's older, and then the more recent hemorrhage on top. Or it may just appear as small clots adherent to the corneal endothelium. While trauma is an obvious cause of hyphema, intraocular disease is probably a more common cause, especially those conditions that cause uveitis and neovascularization, or formation of leaky new vessels, which often leak blood into the anterior chamber. Other causes would include intraocular neoplasia, retinal detachments and tears, systemic hypertension, or various bleeding abnormalities. While the anterior chamber has efficient mechanisms to break down fibrin, the resolution of hyphema still requires the exit of intact red blood cells through the aqueous humor outflow channels. One episode of hyphema is not sight-threatening as long as the cause is identified and treated, but recurrent or chronic hyphema has a poor regarded prognosis because it often leads to secondary glaucoma or phthisis bulbi. Here's an older picture of a rat with bilateral hyphema. In rats, it's usually traumatic, but it also may be associated with infection by sialodacryoadenitis virus or coronavirus, or previous corneal injuries. If the eye is successful in breaking down hyphema, you will get a number of products within the eye. Initially, this blood is broken down to hemosiderin and cholesterol, and the condition is known as cholesterolosis bulbi. If you're interested in seeing a great histologic picture of that, the Wednesday slide conference from 2015 has a great case submitted by Jeff Saunders of Virginia Tech. This generally stimulates a profound phagocytic response in the eye, and histologically, you may see hemorrhage crystals at the periphery of the anterior chamber, especially near the outflow tract. Ultimately, you may develop the very beautiful condition known as asteroid hyalosis, which is shown here. We're looking at small refractile opacities ranging from between 4 to 10 microns, which circulate in the vitreous humor sort of like a snow globe. They are also breakdown products of hyphema and consist of lipids embedded in a matrix of calcium and phosphorus. They generally don't cause a tremendous amount of vision impairment to the affected animals. It's another bit of new vocabulary for you, asteroid hyalosis. And it's often the result of previous hemorrhage, but may also be associated with diabetes mellitus, hypertension, hypercholesterolemia, as seen in this case, a tumor of the ciliary body, which is on the back side of the iris and often results in persistent hemorrhage. Here is a case of bilateral proptosis due to trauma. It is most likely a result of blunt trauma, such as being hit by a car, but may also be seen following animals that fight. During this trauma, the glove is luxated from the orbit, and the eyelids actually spasm to prevent its retraction. Shortly, there will be enough swelling of the conjunctiva, the muscles, and the globe itself to prevent the eye from retracting into the orbit. Subsequent hemorrhage seals the deal. This is overwhelmingly a disease of dogs, with only a few cats showing this type of lesion. And it's more common in brachycephalic dogs. It's good that cats don't get it very often because it is usually associated with loss of sight, whereas in the dog, if it's treated quickly and effectively, you may see sight come back in one or both eyes. For a pathologist, the condition is interesting because you can almost stage how long the eye has been proptosed by the amount of damage that you see histologically. The diagnosis of proptosis is made histologically by the presence of global optic nerve necrosis. If the eye has been enucleated within 4 days, you will still see some viable nerve fibers, although they will be degenerate. If the eye is removed 5 to 10 days after proptosis, the dominant picture is malacia of nerve cells. And if it's removed weeks to months later, you will see profound atrophy and fibrosis of the optic nerve, as well as retinal detachment and segmental malacia and atrophy of the retina. There is almost always acute and profound corneal necrosis because of desiccation and the loss of innervation and blood supply to the anterior segments of the eye. Here is a silicone prosthesis, which a number of owners opt to have after enucleation to give their dog a more normal appearance, as we see in the bottom right. This picture in the bottom right with the blue cloudy eye is the optimal result for one of these surgeries. They don't get any better than this. These are known as intrascleral prostheses, and it involves creating an incision over the top of the eye underneath the upper eyelid, right here, removing the contents of the eye and placing these silicone prosthetic devices within the shell of the eye and closing that incision. The pet generally retains the cornea and sclera. But one of the sequelae is that when you shell out the eye, you've removed the blood supply to the cornea, so over time you will get vascular ingrowth from the limbus to resupply the blood supply to the cornea. Eventually that will retract, the vessels will not be as prominent, and you will get sort of this slightly bluish tinge to the newly revascularized cornea. When we look at the surgical success rates, dogs do much better with about a 4% of failure, and cats don't do quite as well. They have about a 15% of failure just in the implantation of the prosthesis. The major reason for failure of prosthetics is most often post-surgical inflammatory disease, followed by a regrowth of the neoplasm for which the eye is enucleated. And you can see that's what happened here. This eye was enucleated because of an intraocular melanoma. Unfortunately, the melanoma continued to grow, and it has replaced about 40% of the back of the eye, pressing the prosthesis forward. Finally, the least common, and a credit to ophthalmic surgeons out there, is a failure of the corneal scleral shell itself. This option, as you can imagine, will be much better for glaucoma, which is a non-inflammatory, non-neoplastic disease, than it would be for other causes. Here is an absolutely fantastic picture from the Animal Eye Institute of a descemetocele, an animal with deep stromal keratitis, with melting of the fibrocytes that compose the corneal stroma, will eventually get to the tough membrane, the last bastion before the lens itself is perforated, and that's Descemet's membrane. On the far side of Descemet's membrane, facing the anterior chamber, will be the corneal epithelium, which helps to produce Descemet's membrane, but really, in terms of preventing perforation, are of no use at all. Descemet's membrane, as seen here, blocking this ulcer, is very resistant to the bacterial and fungal products of the opportunists that may be present in this ulcer, but is very permeable to the cytokines and some of the other factors that are secreted by the inflammatory cells that are present in the ulcer. And you could see an accumulation of pus in the anterior chamber. There's also an anterior uveitis. These are often associated, almost always associated with descemetocele, because while they can block those invaders for a period of time, they just let all of the inflammatory mediators through and generally sets up a very nice anterior uveitis. If the corneal perforation is full, as we see in this horse, you'll develop a staphyloma, in which a staphyloma is simply a word that means that the fibrous tunics or the cornea or sclera of the eye are ruptured, and portions of the uvea or choroid plug the defect. That's all it means. This is also known as iris prolapse, whereas the prognosis for descemetocele is moderate. The prognosis for an iris prolapse is generally very poor. And you'll hear these, as I said before, referred to as an anterior synechia, which is probably not a good term, or an anterior staphyloma, which is a preferred term for this sealing of a hole by the uveal tract. Here is a common condition, especially in older brachycephalic dogs, known as pigmentary keratitis. This ingrowth of pigmented cells most commonly accompanies chronic corneal irritation in the dog and less frequently in other species, including the horse. The pigment is actually brought in from the limbus by new germinal cells, which have retained pigment from the bulbar conjunctiva. The pigment sits in the basal layer of the corneal epithelium, which at this point may be undergoing or already have undergone squamous metaplasia, a change which may also be seen in the superficial corneal stroma in association with chronic stromal inflammation and vascularization. There usually is very little inflammation in these cases, so the term pigmentary keratitis is probably incorrect. Histologically, if you look at the epithelium, these areas, the chronically irritated epithelium may have already undergone metaplastic changes, including rete ridge formation, pigmentation, and surface keratinization of the corneal epithelium. And in really, really bad cases, it may progress to the development of squamous cell carcinoma. Here's an absolutely beautiful lesion of a pigmented area in the central cornea of a cat, probably a Persian or Himalayan. This is a process known as a corneal sequestrum or corneal mummification, and it's a non-inflammatory process resulting from the death of stromal fibrocytes. Histologically, there is minimal change to the affected area of the cornea except for a slight orange discoloration. And this pigment, which appears black here but would appear orangish underneath the microscope, is not melanin, but it's porphyrin from the tear film, as these mummified keratocytes absorb the stain from the tear film. There's almost always evidence of previous ulceration, and it does pop up in the center of cats with flat faces, the least protected area of the cornea. But there's usually very little inflammation. A few leukocytes and rare giant cells may be seen in very long-standing lesions. If untreated, and these most commonly are treated, but if they're untreated, the lesion will eventually slough when the surrounding corneal epithelium has the ability to undermine the lesion, and the defect will fill with granulation tissue, and there will be scarring. For some reason, these desiccated stromal keratocytes have the ability to resist enzymatic degradation from incoming inflammatory cells and the occasional opportunistic bacterial or fungal organisms which may be encapsulated within them. Corneal sequester, a great lesion. Here's another great lesion that we don't see very much anymore because it turned out to be very responsive to immunosuppression, steroids, or nowadays cyclophosphamide. And this is known as pannus. Don't confuse it with the pannus that we see in the joints. But this is pannus of the eye. It is seen most often in German Shepherd dogs. And it's seen with increasing frequency with increasing altitude. So it's thought to be the effect of ultraviolet light on altered ocular antigens, especially changes to the corneal antigens, and the body's response to that. It invariably starts from the lateral limbus and is the result of an influx of inflammatory cells followed by vessels, pigment from that conjunctival site, and corneal epithelial hyperplasia. There is no associated ulceration, but pigmentation is often quite marked. The lesion is confined to the superficial third of the stroma with progressive vascularization and fibroplasia, but the deep stroma is never affected. Because of the advent of immunosuppressive drugs for the eye, we don't see this much anymore. It used to be a big problem with our military working dogs, especially in the Rocky Mountains, but we almost never see it. But here's a case in which the untreated lesion may cover the entire surface of the cornea. When we talked about the viral diseases of the eye in the cat, we talked about herpes viral keratitis and how it might cause an eosinophilic response. Cats will also get eosinophilic keratitis and a form of eosinophilic conjunctivitis, which we'll look at later, which are not associated with herpes viral infections. Eosinophilic keratitis in the cat has a very characteristic presentation in the cat with these fluffy white stromal keratitis. It has a unique look. It has no breed age or sex predilection and no proven association with any other ocular or systemic diseases. If you scrape the surface of the lesion, and the lesion is fairly recent, you may see quite a number of eosinophils and fewer mast cells. But as the lesion gets older, like we see with other conditions in the skin condition known as the eosinophilic granuloma complex in cat, which has never been shown to be associated with this, but the two act very similar. As the lesion ages, the number of eosinophils that you will find will decrease, and you will see a concomitant increase in lymphocytes and plasma cells. An old lesion may simply be a mixture of macrophages, lymphocytes, plasma cells, and fibroblasts. Histologically, on top of this, on the outside of the keratectomy specimen, you may see a dense granular eosinophilic coagulum, which is composed largely of free eosinophil granules and cellular debris. It is primarily a surface corneal lesion with often a plexus of large, newly formed blood vessels in the underlying stroma. But to reiterate, it's never been associated with the eosinophilic granuloma complex in any other part of the cat, nor has this been associated with herpes viral infection. Let's wind down this lecture with some disorders of the corneal endothelium, which can have very significant effects on the rest of the cornea. This is a Boston Terrier, and along with Chihuahuas and German Shepherds, these animals suffer from a well-known corneal endothelial dystrophy, which causes slowly progressive bilateral corneal edema, usually in young dogs. The lesions often begin adjacent to the lateral limbus, and the loss of the corneal endothelium results in absorption of fluid into the cornea and may cause large epithelial fluid bullae within the cornea. They're often associated with overlying corneal defects, which may be the result of the fluid accumulation within the cornea, or may be secondary to damage from these brachycephalic animals running into things with the blind eye. The condition is characterized here by persistent stromal edema and fibrosis. The vascularization is often not seen unless the formation of bulla and rupture initiate keratitis. The primary lesion is endothelial cell attenuation and ultimately loss, but no one understands the underlying pathogenic mechanism at this time. Collies, collie mixes, and Shetland sheepdogs are sometimes affected by a corneal epithelial dystrophy called superficial punctate keratopathy, which causes a number of shallow corneal ulcers, giving the cornea sort of a orange peel appearance. Ultimately, you may have fibrosis and mineralization, resulting in this sort of starry sky appearance. Our last condition for this particular lecture is a devastating, often rapidly appearing condition known as bullous keratopathy in cats. This disease may have a repetitive, fast onset, and the other term for this condition is acute bullous keratopathy. It is characterized by rapidly developing edema with large coalescent bulla formation within the stroma and gross distortion of the corneal profile as seen from the side or keratoconus. Histologically, you'll see marked stromal edema with rupture of Descemet's membrane, but little or no inflammation. Young cats are usually affected, and the problem is usually bilateral. And here we can see the change to the cornea in one of these cats. This condition is also known as corneal hydrops. And underneath here you will see a break in Descemet's membrane. Once again, the pathogenic mechanism is not known. It affects young cats, and as you can imagine, can have significant impacts on vision and the ability to save the eye. Well, that concludes the 5th lecture. I think we'll have 2 more lectures. In the next lecture, we will talk about diseases of the lens and vitreous. And we will finish this series with the 7th lecture, which we will talk about neoplasia of the eye. I hope you've enjoyed this lecture. I hope you will continue to visit the Foundation's YouTube channel or our Facebook page, where we will post these lectures in the future. Thanks for your time and attention.